Hi, everyone. If you're just logging in right now, we're going to get started in about 1 minute. So if you just want to sit back and relax, the speakers will join you in just a second. Good afternoon, everyone. It's 4:01, so I think we'll get started. I just wanted to thank everyone and welcome everyone to today's webinar. I'm going to turn it over to the speakers in just a moment, but I wanted to cover a few housekeeping things while we get started. So the first thing I just want to flag is that we're delighted that we have many people joining us today. But as a result of that, we are going to leave all of the attendees muted for the duration of the session. But you do have a Q&A feature at the bottom of Zoom. So if you have any questions, we would be delighted to receive them. So please feel free to add your questions to the Q&A section over the course of the webinar. And I'll be keeping an eye on the Q&A box, and we've left lots of time for questions at the end. So please feel free to add those. Today's webinar will be starting in just a moment, and we're scheduled to go through until 5:30. And one question that many people have asked is whether or not this will be recorded, and the session will be recorded and a link will be sent out to you after. So if you have a colleague who wasn't able to attend, you'll be able to pass that on. And with that in mind, I think we've got a busy agenda, so I will turn things over to our first speaker today. So Imtiaz, I'll turn things over to you.
Thanks, Daniel. Hello, everyone, and welcome to the three-part educational series on how measurement-based care can drive improved patient outcomes and more integrated and efficient service delivery. My name is Imtiaz Daniel. I am the Chief of Research and Analysis at the Ontario Hospital Association. On behalf of the OHA, the Ontario Mental Health and Addictions Center of Excellence, and the University of Toronto Institute of Health Policy, Management and Evaluation, we are pleased to host a webinar series addressing why Ontario should apply measurement-based care in mental health and addiction services, how it is being implemented in clinical practices, and what we need to do to overcome challenges in Ontario. I'd like to introduce you to Dr. Paul Kurdiak, who's a medical lead for Mental Health and Addiction Center of Excellence. And he's leading the first part of the education webinar series with Dr. David Clark. We're very fortunate to have David with us. He's the National Clinical and Informatics Advisor of the UK's Improving Access to Psychological Therapies IAP program. And without further ado, I'll hand it over to Paul. Paul, you're on mute.
Thank you, Imtiaz, for the introduction, and thank you, everybody, for attending. So today, I'm just going to provide a very brief background to sort of set the context for what we're going to be speaking about today and what we're going to be covering for the whole webinar. So I think the first issue is to take a step back and think about measurement-based care as it could or should be applied to mental health and addiction service provision. So the next slide, please. So I just wanted to have a very quick definition so that we're on the same page. So there's a definition there: the routine systematic use of validated measures integrated into routine clinical practice. And this is normal. So we often think only within our own sector, but it is a normal part of care. In fact, it would seem kind of odd and inefficient if we didn't integrate it. But I also want to focus on diabetes because I think it's reasonable to think about the processes required for doing measurement-based care in the provision of diabetes from a process perspective. And very briefly, there's an appointment made. The primary care physician typically has to assess the patient and then fulfill an order request for laboratory tests. Usually the patient has to take the printout of the laboratory request, or it goes direct to the laboratory. Then the patient has to go to a laboratory, have blood drawn, have the drawn blood analyzed, have the analysis reported, have the report sent back to a primary care physician, have the primary care physician spend time interpreting the results, and then have the care of the individual managed. So that's a very complex undertaking, and yet the healthcare system has managed to integrate all of those processes rather seamlessly. And when we think about measurement-based care for mental health and addictions, it's not happened despite the fact that usually what is required is the administration of a scale that often takes 3 to 5 minutes to complete, and then the information integrated into care. So if we can do it for something as complex as diabetes, that really we want to be thinking about what it would take to do it for something like mental health or addictions service delivery. So the next question asks the big picture. Next slide, please. Why should we be thinking about measurement-based care systematically? There is overwhelming evidence now that when measurement-based care is integrated into the routine provision of services, it outperforms. You get better outcomes than treatment as usual. And there's a transparency and response to treatment for both the provider and the patient or client. And often patients or clients can more meaningfully engage in self-management through access to their response to treatment. And for the providers, it really helps support clinical judgment and ensures a real objective assessment of how patients or clients are doing. Next slide. It's important to think about why measurement-based care is essential for organizations. And right now, many organizations have invested or are considering investing in electronic health records. So there's a real opportunity to think about the integration of measurement-based care as we design these platforms. It can really provide real-world understanding of effectiveness of programming. It also, in the area of mental health and addictions care, for the first time, can provide real-world understanding of the populations we're serving. You really need this kind of information for iterative quality improvement, and without it, you're really working in the dark. And it really supports integration and system development. And finally, at the system level, which is sort of the sky-high version of things, and this is the area. Next slide, please. This is the area where my ICS team has done some work with the administrative data, but we really don't have much data to help us understand the mental health system as it currently exists. And what we do have helps us understand individuals, broad diagnostic categories, and broad types of treatments. But with very rare exceptions, we do not monitor outcomes or response to treatment in the individuals we serve. And without that, we really don't understand, we can't understand the performance of the mental health system. Next slide. So this slide is meant to prompt me to say, well, it's obvious why we should do it, and yet measurement-based care has been so meaningfully integrated into other areas of the healthcare sector, but not mental health and addiction system. Why is that? And I think that'll be something we need to be thinking about as this webinar unfolds. But now I'd like to pose a different response to the why measurement-based care by handing things over to Dr. David Clark. I met David when he was helping all of us think about emulating his amazing initiative in England. And he's been so generous with his time and expertise in sort of showing us the way. What I would say is that a lot of people talk about the impact of administering CBT to the population of need in England. And that is monumental. But for me, what is equally, if not more monumental, is the way in which David achieved his results, starting with a really clear and articulated business case from a health economics perspective, and then being able to tell the story with such a rigorous, data-informed and measurement-based approach that has allowed him to sustainably develop this what I consider to be the most influential mental health system innovation in my career that I've seen to date. So it's with great pleasure that I hand things over to David Clark, who's going to talk to us about how data and measurement-based care has led to his unbelievable success in England.
Well, thank you very much, Paul, and it's really a pleasure to join you all this afternoon or this evening here in Oxford, where I am. I've been following the developments in Toronto and Ontario for several years, and have been lucky to meet Paul and his colleagues on several visits, and it's really exciting what you are doing, and it's just a pleasure to join you for some of your discussions of how you want to take things forward. And I'm going to focus, as Paul said, on the value of getting systematic outcome data from psychotherapies and what you can do with that data. But firstly, how you solve the problem of getting it in the first place. So I'm just going to do a quick screen share so that we can get onto the PowerPoint. So I'm going to sort of take you through the large sort of program that we've been developing in England to improve access to psychological therapies, which we call IAPT, or Improving Access to Psychological Therapies. I'm going to tell you a little bit about what it's achieved so far, and then focus on the central nature of the data and why that's really helped us enormously. So IAPT was created to solve a problem. What was the problem? Well, the problem was that in round about 2005, a government body that reviews the evidence for the effectiveness of interventions across the whole of medicine, which is called NICE, started to issue recommendations on the treatment of mental health conditions. And those recommendations were very clear in saying that evidence-based psychological therapies, of a range of them, should be first-line interventions for depression and all the anxiety disorders, of course, along with effective medications. Surveys of the public really throughout the Western world have showed pretty consistently that although some people very much prefer medication, if you ask people what would be your preference if you had a choice between psychological therapy and medication, people go in a ratio of 3 to 1 for psychological therapies. But there is no country in the world where the public gets what it wants. There is no country where psychological therapies are more widely available than medication. And in England, the situation was really bad before we started the IAPT program. We found that less than 5% of people had received a NICE recommended psychological therapy for a common mental health problem in the last year. More people had some form of psychological therapy, but it often wasn't evidence-based. And the waits for evidence-based treatment were well over a year. So the IAPT solution to that is to train a large number of psychological therapists using national curricula to acquire the sort of skills that are needed for the evidence-based treatments, which in anxiety disorders, it was predominantly CBT, but in depression, it's a range of therapies: CBT, interpersonal psychotherapy, brief dynamic psychotherapy, and counseling and couples therapy. Currently, we've trained about 8,000 therapists, and we deploy them in stepped care services for depression and anxiety disorders. So some of the milder cases may be offered what we call low intensity interventions, such as guided self-help, computerized CBT, and many people respond very well to that. But for those who don't, they then get stepped up to more conventional face-to-face therapy, and that's also the more severe people would go straight to that. A key feature of the program, though, was the aim to measure and publicly report the clinical outcomes of every single patient who receives a course of treatment. So a real unique exercise in public transparency. And part of the reason for this was, of course, that this was going to be an expensive initiative, and the government wanted to know that its money was well spent. But as you'll see in a moment, there are other reasons as well. When the national rollout was announced, which was back in 2008, the government realized this was really something quite radical, and spoke about it in quite visionary terms. So the health secretary at the time said, "We will build a groundbreaking psychological therapy service in England." He committed us to getting at least 50% of people to fully recover from their anxiety and depression, because I told him that's what you could get if you got results as good as the randomized controlled trials and you train people well enough. And he also committed to our waiting times coming down from the 18 months, which was the average at the time, to just a few weeks. What were the sort of arguments that persuaded the government to go for this? Well, the first one was actually a straightforward economic argument. Untreated anxiety and depression is very expensive to society. It's estimated in most Western countries, and it certainly applies to Canada, that your gross domestic product is reduced by about 4 percentage points by untreated anxiety and depression. That's partly, of course, when people are at work, they're much less productive because their mind's on their worries and their anxiety. So that's what we call presenteeism. And that, of course, costs society a lot in terms of industrial output, but also absenteeism. Many people finding that they can't work full-time or sometimes not at all because of their mental health problem. Of course, psychological therapies are more complex than medication. With medication, generally each tablet has the right dose of the chemical in it. But with psychological therapies, unless it's delivered by someone who is fully trained and is competent to deliver the therapy, you're not going to get the outcomes you'd expect. You're essentially delivering something more like a placebo, and you'll get attenuated effects. But there were a number of demonstrations that it is possible to train therapists in routine services to deliver treatments effectively. There were small demonstrations at the time, but it was thought there was a good proof of concept there. Of course, because if the therapies aren't delivered well, the results won't be as good as you would like. It is really important to check whether in any new initiative you are really achieving the outcomes you expected. And so we had to have a system for ensuring we could do that. And the system that we chose was one that was developed from tragedy. This is a picture of Northern Ireland. It was it's Omagh, and a car bomb exploded as the last of the events in the Northern Ireland Troubles, killed 30 people and 2 unborn children, and injured 530 people. And for those people who survived, there were very high rates of PTSD and other mental health problems. And we set up a treatment clinic to help those people. But for various reasons, it couldn't be run in the normal health service. And it was also unclear how effective it would be. And it was unclear whether people would come back to their next session because it was just a walk-in center. And so we developed a session-by-session outcome monitoring system where people were given a measure each time they were seen. So even if they didn't come back after the third or fourth session, you'd have the last available score. So you get an idea of whether they benefited. And that worked very well. We got outcome data on more or less everyone. And so we thought we'd apply that to the IAPT initiative. The other, of course, crucial bit of the argument, which Paul has alluded to, is that the calculation was that if you implement psychological therapies in a step care fashion, it will be a minimal net cost. So the savings to the health service will at least equal and often exceed the cost of delivery because of the sort of broad economic benefits and savings to the NHS itself, because many people would need a lot less physical health care if their mental health problem is helped. These arguments are outlined in detail in the book that Richard Layard and I wrote called Thrive, The Power of Psychological Therapies. This is the UK version. And if you want to see them in detail, you can pick it up there. But in fact, the North American version is this much more bright yellow version, slightly different title, which really tells you what's in the tin. Thrive, How Better Mental Health Care Transforms Lives and Saves Money. In Europe, the idea has really taken off, and this is the Dutch version of the book with a very clever title, Therapy Winst, which in Dutch translates to therapy profit, illustrating the dual thing that patients profit by their lives improving, but also society profits by the economic benefits. So that's the sort of background to the program and the arguments that were used to start it off. What has it achieved now 12 years into the program? Well, we now have one of these IAPT services in every health area in the country. They're called CCGs, or clinical commissioning groups. We're currently seeing about 1.1 million people in the services. The services have a sort of assessment and triage function. So some people just get some advice, they don't need formal treatment or signposting elsewhere. But we give a course of treatment to just over 600,000 people each year, using the step care model with CBT for anxiety disorders, and then a range of other treatments for depression. And the first goal has been achieved. So the minister, when he committed to ensuring that people have treatment within just a few weeks, he got what he asked for. The average waiting time is just 20 days, down from the 18 months that we had at the start of the program. But of course, what you really want to know is, does it achieve the outcomes that it promised? The first thing, of course, is, have we managed to get outcome data on everyone? That was a big challenge. There was an audit of counselling and psychotherapy services in England before the IAPT program started. And that audit showed that we were only able at that time to get outcome data on 38% of people treated in our counselling and psychotherapy services. But using this session-by-session measure, IAPT records over pre and post treatment measures in over 99% of cases. It's currently 99.4% of that 606,000 people a year. So what does the data show? Well, currently we are getting the outcomes that were promised by the government. So around 7 in every 10 patients who are treated, it's actually currently 68%, show substantial reductions in their anxiety and depression, what we call reliable improvement. And 5 in every 10 fully recover. So they're below the clinical threshold in both anxiety and depression at the end. It's 52%. But as you will see from this graph, that is not where we started. So you can see this is the years of the program. And by the end of the first year, we were just at 40%. And if we hadn't been collecting outcome data on everyone, we would still be at 40%. And we'd be blissfully ignorant of the fact that we hadn't achieved what we'd intended, because we would have been able to assure ourselves that we trained everyone in the right therapies. We put them through good training courses. And at the end of the courses, they'd passed out showing that they had the relevant competencies. So I think we would have just blithely assumed we were doing what we thought we would do. But of course, we would have been mistaken. But because we had data on everyone, we could see at the start there was a big gap from the aspiration 50% recovery from where we were. And so a lot of hard work was done in the next few years of the rollout as we expanded the service in order to try and get us to that 50% target. And I'm pleased to say that about 4 years ago, we reached it as a nation, and we stayed effectively above it more or less ever since. So how has that been achieved? If it hasn't been achieved by improvements in training, that stayed the same. What's been going on? Well, it's essentially the use of the data that has allowed us to learn many things about how to more effectively deliver these treatments and get that big step up in outcomes. And this graph here shows you the sort of transformation that's occurred. So this is the sort of average recovery rate in 2015, 45%. And over the next 4 years, it got up to our current level, 52%. So that's a national average. But what I want to draw your attention to is these two other lines in the graph. The bottom one is the outcomes of the lowest 10% of services in terms of performance. And the other one is the top 10%. And you can see that what's happened over time is that the poorer performers have greatly improved. They are really making a very big difference to the outcomes that they've achieved. The top performers have carried on being top performers, but they haven't changed so much. But the consequence of this is we've greatly reduced the amount of variability in outcomes between different services. So it was about 20 percentage points. It's now down to about 10 percentage points. So a real improvement in the consistency of the outcomes. The lessons that we've learned from the data are numerous, and there isn't enough time to tell you all of them, but you will find all of them in the IAP manual, which you can download for free from the NHS England website. But I want to just cover some of the key findings and show how they've helped us. So this is an analysis that we published a little while ago in Lancet, where we looked at predictors of reliable improvement and recovery, rate differences in those rates between different IAP services, using data from 2016. And what we found is that services varied quite a lot in the quality of their assessment. Some were really good at identifying the key mental health problem and giving a sort of problem descriptor that you're going to focus on in treatment. Others were less consistent in doing that. And the quality of that assessment was important. Those services that got higher problem descriptor completeness got better outcomes on average. Just like in medication, there's also a dose response effect. Those services that give a higher average number of sessions get better outcomes. And how long you wait to start treatment also turned out to be crucial. And you see this on this graph here. So each dot is the outcomes of all the patients treated in a service in a year. So each dot represents about 7,000 patients. And this is the average number of days people will have to wait to start treatment in that particular service. And this is the likelihood that they will have reliably improved by the end of their treatment on average in that service. And you can see that it doesn't really matter how long you have to wait in a particular service before you start treatment, if it's up to about 6 weeks. But after that, then there's quite a drop-off in the outcomes that the services achieve. As a consequence of this, the government has set as a target of getting most people to start treatment within 6 weeks. Stepping people up if they don't respond also is very important. And lastly, you'll see that the social deprivation of the area that people live in and the services based in is important. Those services in more socially deprived areas, on average, got less good outcomes. But we found that this effect is greatly attenuated if the service pays attention to these quality factors. And this is, but that's a sort of correlation. The question is, can you use this information to improve the performance of the services? So these results were available from our analyses in 2016. So we then did a whole series of training events for all the IAP services, making them aware of those results and encouraging them to change these variables in the right direction. And on average, that's what they did. So you can see between 2016 and 2019, problem descriptor completeness increased substantially. So did the average number of sessions. Weights came down, step-up rates went up. And if you then look at the relationship between change in these variables and the clinical outcomes that services achieve, you can see there's a very strong relationship. So the multiple R squared measure of how much variance in improved outcomes is determined by improvements in these variables. The multiple R squared is 53% or 0.53 for reliable improvement and 0.55 for recovery. So these factors are really important. I mentioned that social deprivation is important, but I also said that this effect can be finessed if you have a good quality service. And this is nicely illustrated here, where there are two areas of England which are right next to each other and vary a lot in social deprivation. So at the moment in COVID, the Queen is largely self-isolating in Windsor Castle. And the area around Windsor is not socially deprived. It's just at the 4th percentile nationally for social deprivation. But it's right next to one of the most socially deprived areas in the south of England called Slough. And but luckily, both areas are served by one top quality IAP service, and both of them have outcomes better than the national average. And if anything, Slough does slightly better. The services in the deprived areas, of course, have paid a lot of attention to these findings and have worked hard to improve on these key features. And this has worked out very nicely, and you can see that on this slide here. So this is looking at the improvements in reliable improvement rates between 2016 and 2019 as a function of social deprivation. And you can see that those services in the most socially deprived areas have improved most in their outcomes, and it's largely due to changing these factors that we identified from the analyses. So that's sort of showing you that if you can get the data, you can do wonderful things with it, and you really can improve the outcomes that your patients achieve, which is, of course, what we're all in the business of doing. It's why we all got into mental health in the first place. But I'd like to really first look at the question of, do you really have to get data on everyone? Because in England, you know, before IAPT, we were getting data on 38% of people just, but people said that doesn't really matter because the people that you don't collect the data on, it's just sort of random. They didn't turn up on a particular day or something. So you can safely assume that the people whom you have missing data for will have improved as much as those that you've got data for. And obviously that's a possibility. But the other possibility is there's some systematic bias there. And early in the IAP program, we got a chance to test that out, because in some pilot services, we gave the session-by-session measures, which get an endpoint for almost everyone. And at the same time, we gave a conventional NHS measurement system where you just got data at the beginning of treatment and then tried to get it at the end. And what we found is in the conventional system, we only got post-treatment data on 50% of people. But with the session-by-session system, we got data on essentially everyone, 99%. So we now know what happened to everyone, and we can see whether the people who you normally would get missing data for have done as well or not. And the answer is not. So here you can see that the people who in your conventional system where you don't get data on everyone, the people that you don't get data on have the post-missing group have only improved 40% as much as those that you would normally get your outcome data on. So this led us and the government to conclude that we're simply deluding ourselves about how good our mental health services are unless we get data on everyone, because we're systematically losing data on the people who do least well. So that's why the IAP program has really baked in the idea of collecting data on a session-by-session basis. But there are several other steps that we've taken in order to quickly get to a point where we got complete data on everyone. And one of the critical decisions was to decide to publish the outcomes of our services quite early in the program. This was controversial, and there was lots of internal discussion about it. People said, well, early in the program, maybe you won't get such good outcomes as later. Maybe we should just wait until the outcomes look better before publishing them. But the other view was to say, well, but if we publish things, then people will pay more attention to them, and that will help them to work on improving things. And that was the argument that won the day. And so we started publishing very early, not in the first year, but after a couple of years. And if you were to Google right now, Common Mental Health Disorders Profiles tool, you'd be able to see the outcome data of every IAP service in the country. This is a screenshot for the services around the area where I live in Oxford. And you can see we have some variability in outcomes. The highest performing service is getting recovery rates of 61%. Almost all of them are 50% or above, but there's one that's down at 43%, which would have looked very good several years ago, but of course is a bit of an outlier now. So that has been critical. The other thing is a critical decision about the metrics you use. So one of our metrics is a percentage of people who recover. And there are two ways that you could calculate that. And that's really illustrated in this table here. The sort of routine, perhaps normal way of calculating that is to essentially report the percentage of people who have recovered among those that you got data for. So for example, if you treated 1,000 people and then you got data on half of them, which is the sort of conventional data system norm really. So 500 people gave you pre and post treatment measures. And then you are very pleased to discover that 250 of that 500 had fully recovered. You might then say, so our recovery rate is 50%. We decided not to do that. We use what we call a SMART measure. A SMART measure is one that we think will help change behavior as well as record something, and so would move the system on quickly. And so for the SMART measure, which is our actual national measure, if you treat 1,000 people and you only get data on 500 and 250 of them improve, then the recovery rate that's published is 25%, not 50%. The decision to use this very strict measure turned out to be very effective. We found that within a year, all of our services had moved to a point where they're reporting outcome data on at least 90% of all of their patients. We had another mental health initiative that was started shortly after IAPT, which decided to go for the routine measurement. And 8 years later, they are still only getting data on less than half of their patients. So this rather strict metric did seem to produce really important behavior change. What else is important to get complete data? Well, obviously the people who are seeing the data really need to know that it's valuable and be motivated to get it. So it's very important to demonstrate its value to therapists. And we do that by including in our training programs a lot of detail about how you can use the session-by-session measures to guide therapy and make decisions about what you're doing in the next therapy session with that data. We also have an outcome-focused weekly supervision for all therapists, and part of that is actually the supervisor and the therapist seeing the week-by-week outcome data and reflecting on that, thinking, well, what's really worked, what hasn't worked so well, and using that information in their ongoing formulation. Patients, of course, who are asked to fill these in need to know that it's worth filling them in. And so we make a point of ensuring that patients can see graphs of their progress in therapy sessions, and also that their therapists are clearly demonstrating that they are interested in the measures that the patients have been completing by reviewing them with them each session and discussing why things got worse or got better in the intervening week. But you've also got to make it really easy for people to collect the data and to view it. And that really means having an IT system that supports clinicians so that they're not spending vast amounts of time on this activity. Instead, they've got a system which would automatically score the questionnaires and display the measures and also support them in supervision. And when they get particularly interested in looking at how they're going with a particular group of patients, they could run local reports to see how things are going. And lastly, because we also report the data nationally, in our case, we want the system to automatically transmit the data once a month to a central processing house for national processing. This doesn't have to be very expensive, particularly if it's a system that's really built around your psychotherapy initiative and its needs. So the IT systems we're using in England cost on average about $4 Canadian per patient, really very modest compared to the cost of delivering the treatment. At the start, our data entry was really just paper and pencil with questionnaires, but that's rather cumbersome. And as time's gone on, we've moved to having online portals where people can enter the data remotely. Initially, this was by an email link, but recently we've moved to SMS links to patients' phones, and they click on that, and that gets them to be able to input the data on their phone. And we find this works much better. You get a much higher response rate from the SMS messages. And when people do respond, they also respond much faster. So I was in a talk this morning by one of the IT systems, and they were saying on average, people are responding within 9 minutes to the SMS messages, where it was on average 90 minutes to the emails, and many less people were responding at all. Of course, you need to make the data work for you so that you really think it's worthwhile. And there are some pretty important things to think about to make sure you do that. The first is really the quality of the clinical leadership in the services. You need to have clinical leaders who are really creating an innovation environment, getting everyone interested in the data, because we can learn things from it and evolve our service in a way which will make a greater offer to the public. And that's got to be done in a spirit of excitement rather than some sort of punitive environment where you're saying, well, we're just not doing as well as we should do. So you need good leadership to get that dynamic right so people are excited. Of course, it's also important to think a bit about your metrics. If you have just a single metric, say like recovery rates, which is just one of the ones we use, or a particular way of measuring weights, maybe just to the first therapy session, there's always a possibility that people might start to gain that metric, think of ways in which they could look good on it, even if they haven't improved as much as one would really think. So the metric itself takes over as your target rather than the goal of really getting patients better. And we found that a very important way of avoiding that is to actually publish a large amount of data, multiple measures, so that although you might have an official metric, you can look in much more detail in the round. So we publish effect sizes, reliable improvement rates, not just symptoms, but also disability. So you can look at all of these. And with weights, although we have an official measure, weight to the first session, we also can check that people aren't gaming things by then after the first session, introducing a long weight then, because we publish these intermediate weights as well. It's also, I think, good to get multiple heads together to look at the data and learn from it. So we encourage services to get together and form collaborative networks where they share ideas, launch local research projects to try and improve in certain areas, and then monitor how they do. And I've put on the right-hand side of this slide just a couple of illustrations of that recently from the area that I work in, the Oxford region. So one of the things that we noticed was that although the services all give the standard measures of depression, which is the PHQ-9, and of anxiety, which is the GAD-7, services were less consistent in giving some more specific measures tailored to particular anxiety problems. So, for example, in PTSD, the PCL-5 or the impact of event scale. And we do know from other research that if you give the more specific measures, it helps you focus therapy more precisely, and you tend to get better outcomes. So every 3 months, our local services, there are 8 of them, met and reviewed how they're each doing in terms of ensuring consistent use of the PTSD measures. And when we started this initiative in 2017, only 26% of PTSD cases were getting these measures. But now we're up to 84%, really just by brainstorming among all the different clinical leads about what they can do to try and move this rate up. And of course, it's worked very well and outcomes have improved. We also use data to really demonstrate to our commissioners that we are saving the money, because that was part of the argument behind IAPT, and it's part of the argument for its consistent expansion. And so locally, we developed what we call IAPT long-term conditions services. These are special services that treat people who are not only anxious and depressed, but have a long-term physical health condition, cardiovascular disease, chronic obstructive pulmonary disease, and now currently long COVID. And we wanted to see whether if we introduce these services, which have certain special features, that will save the NHS money in physical healthcare. And so we used a sort of stepped wedge rollout, where we started them in some areas before others, but monitored the costs of other hospital care and GP attendance data for physical health problems before and after. And what we demonstrated was really very large savings in physical healthcare in those areas which had the rollout earliest, which of course has really released extra resources for more psychological therapy. So I'm just going to wind up quickly by talking about something that of course is everyone's lives at the moment, this horrible virus that we can see on the screen, COVID-19. And of course, it's affected IAPT like everything else. So what's been the response to IAPT, and has data helped us? Well, IAPT was definitely not involved in anyone's pandemic plans, but we found that we either had to close our services or move to remote delivery because it just wasn't safe to do the face-to-face work. And within about 3 weeks, the whole program moved to remote delivery, with therapists all working from home and delivering therapy remotely by telephone or video. And video was the thing that really increased the most by about 1,600%. But of course, we hadn't been doing a lot of this work before, and it wasn't much in the randomized controlled trials. So this was really uncharted territory. But thankfully, because we collect all the outcome data, we've been able to look at what's happening and has it worked? And it has. So this is the outcome data from the first 3 months before COVID hit the UK. And then we had our lockdown in March and April and May. And you can see there is a bit of a drop in recovery rates in March and April as the services were adjusting to remote delivery. But we worked very hard to give them a lot of extra training in how to do that delivery well. And also they adjusted to working away from the office. And very soon we got back up to our standard recovery levels and have stayed that way ever since. This is the latest sort of publicly available data, but I can tell you we're still that way in the sort of internal data we have. And here's the reliable improvement rates. And the interesting thing is that those last 3 months have the highest reliable improvement rates we've had for any months since 2008. And also in doing this remote delivery, we've managed to maintain the number of courses of treatment that we deliver. The workforce has delivered just as many courses of treatment as before. Why might the outcomes be getting slightly better? Well, it takes us back to one of those earlier slides where I showed you that the average number of sessions that a service gives is important. And what we found is that those therapists who are working from home, perhaps spending less time traveling between centers and things, are actually giving a higher average number of sessions. And that's one reason why we seem to be doing so well. But with all the data we're collecting, we're also learning other things. And one of the big surprises to us is that if you look at whether people turn up for the sessions in psychotherapy, there's always a certain number of people who don't turn up to a session that's been scheduled. For face-to-face therapy, it is round about 6 to 7%. And in remote delivery via telephone, it's about the same. But what we found is that by the video, it's substantially lower. It's only half that rate. And of course, we've asked patients what's going on there. And many of them have said, well, if it's a video link, then I know that I'm not going to have to travel. So the argument that it's too difficult to get to the appointment in the time I've got doesn't apply. But I know there's someone else there waiting for me if it's a video. I can sort of visualize them. And I certainly can't let them down, even if I'm feeling quite rotten. And so we're getting really good compliance through the video link, which is something that's a learning experience for us. And as the vaccines take effect and we hopefully get back to a more normal life, we will, of course, have more face-to-face therapy. But COVID has taught us that we can do lots of good things with video, and that will be a more prominent part of the program, especially as we've now learned how to do it well. Some of the learning that we've had, you will find on the COVID resources website on my clinic, oxcadatresources.com. It's a free therapist website. So if you want to log in, you can see our webinars on how to do remote treatment for different anxiety-related conditions, some written guides about how to treat PTSD following stays in intensive care units for COVID, and lots of video clips about how to do it all. But that's really covered everything I wanted to cover. Thank you so much for your patience listening. Of course, giving a talk like this, you're really standing on the work of a vast workforce who are really the people who've done all the work. So I'd like to acknowledge the absolutely extraordinary IAT workforce, who we view as some of the national treasures in the NHS in England. And they are assisted by 4 different government bodies. So thank you very much.
Thank you very, very much, David. It's a testament to the quality of your work and the quality of your presentation skills and the immensity of the work. I actually learn things every time you present. And you know, the message I heard in relation to this measurement-based care was how, in the absence of measurement, we can be blissfully unaware of the low performance that we are doing, and that the only way to address that blissful ignorance is through a data and measurement proposition. And the other interesting finding, that even though I've read your Lancet article a number of times, it eluded me, and this is something that's of interest to a lot of us who are thinking about issues related to equity. If I understood you correctly, that what your Lancet article showed, that is an attention to how you go about delivering care. In other words, assuring quality in and of itself can address issues related to marginalization.
Yes, yeah, and it's a big effect.
So that is a big and a profound effect, because we often think about the complexities of addressing issues related to marginalization when quality in and of itself can go a long way, and there are probably other issues. There are lots of questions. I wanted to start with one because this is one that you know, there's lots hidden. There's lots of complexity hidden in the elegance of your presentation, but you know, there are many. So there's the measurement, and there's the transparency, and then there's the emotional response by providers to said transparency.
Yes.
Seems to me that there was something magic about this where you mentioned, there was sort of evidence of it, the community building, the willingness to collaborate and work together, a spirit of innovation. Can you talk to us about your thoughts now, this many years in, how that developed versus a suspicion about being accountable to measurement as another alternative response to measurement? Like, how did you develop the culture and community of transparency in the program?
Yeah. So, I mean, firstly, there was a sort of strategic decision that we made early on. Back in 2007, when we really got going with the program, we thought many of the ideas in IAPT were pretty radical. And we were aware that quite a number of members of my own profession, clinical psychology, didn't really like the idea of measuring outcomes every session. They might say, well, we're not sure we have valid measures for things. And also, they didn't like the idea of data being published. They certainly didn't like the idea of data on their own outcomes being published. And we don't actually do that. We only publish for the whole service, not individual therapists. But it's quite clear that not everyone really wanted to do that. And we thought it would be very unwise and unhelpful if we just tried to impose that way of working on everyone. And so what we said is, well, we know that there is vast undertreatment of mental health problems. Only a small proportion of people get services. So we've got some extra money and we're going to add something on top of our existing services. So rather than force existing services all to change, we said we'd create a new set of services, IAPT services, which would be additional. And if you would like to work in those services, then you're really very welcome, but you need to know that they have these particular features. And one of them is collecting outcome data on everyone and using that to improve the services, and also guaranteeing that you're going to get really good quality supervision every week linked to that. And so I think I would describe it as an initiative where we decided we would run it by getting people to opt into the revolution rather than forcing them to change. And that worked really well because it meant that the services, kicked off well. They had a very good spirit. The clinical leads were all chosen because they were passionate about the data and weren't punitive about the data, just were interested in it. And, they passed that idea on to other people. And of course, they've evolved well. Now, of course, it's a very large program. And many of those people who were more skeptical about it early on have now joined. But they've done that because they've been able to observe that it works well, rather than because they were forced into it. And I think that was really pretty crucial. But the other thing is, to have lots of discussion in the services, and these collaborative networks encourage people to discuss, difficulties in collecting the data and when it's useful and when it isn't. And we all work together to evolve to a system that we all think is helpful. So it's a coalition of the willing. There is another thing, of course, which is that obviously in new initiatives like this, they tend to attract somewhat younger people, somewhat earlier in their career in many ways. And for them, I think these new ways of working are just very exciting. And I think, when you do a big change, you don't necessarily want to do it in a way where you're trying to force very experienced people to change if they don't want to. It's more a matter of evolving the change among those people who are still in the earlier stages of their career, and that seems to work very well.
And the other point is that
but it is important, I think, to have the whole service doing it. So we do have an example in England where another evolving service decided that they would want to do outcome monitoring, but they would only ask the junior staff to do it initially, not the supervisors. And that really worked out very badly because, of course, the supervisors are very senior authoritative people, and the junior people quickly stopped using the measures because they weren't being used by the seniors. So you do need to lead by example within these services.
This question may put you on the spot, and I think we're going to open it up because my understanding from Danielle is we're getting lots of questions. But you've been helping us for a number of years now, including pre-pandemic, coming and visiting and spending time with members of the Ministries of Health and the individuals who are involved with implementing it. And I should mention my understanding is that Dr. Martin Antony is here as well. We want to acknowledge his excellent clinical leadership involved with the Ontario initiative. Knowing what you know from your visits to Ontario and talking with a variety of stakeholders and implementers, and knowing the environment in England with NICE and the structure of the healthcare systems, can you comment on, barriers and facilitators or system differences that we might consider as we continue to roll this out and implement it?
Well, I mean, I think the first thing to say is, of course, it's wonderful to have you and Marty Antony working locally, because people just making suggestions from another country tend not to be anywhere near as effective as having real local experts. And I think Ontario is very lucky to have both of you working so hard on this initiative. What are the differences? Well, I'm not sure the differences are very large. I mean, in England, we certainly had a lot of dispute about, whether it's valid to use measures at all. People sometimes say, well, there's no measure that's perfect, and therefore, and there's no measure that everyone agrees on, and therefore, we can't progress. And that's the sort of classic problem of, perfection being the enemy of good, and you're just not making any progress. And so we did something which I know you're also thinking of doing, which is essentially trying to develop a consensus about the least bad measures, or the ones that everyone agrees would be reasonable as a minimum data set, and then develop it like that. And that, I think, was a very helpful way forward. But calling it the minimum data set is really quite important, because many of us might want to give some other measures that we particularly cherish to guide our therapy on top of that. And that is not prevented from any of this. But the other thing that we had, and I think you have it as well to some extent, is that it's not easy. People were just doing these pen and pencil measures, and then it was being stuck in a filing cabinet, and then someone had to put them into an Excel spreadsheet, and the whole process of collating the data was very burdensome, and people don't have the time to do that. And so I think it was very helpful to have develop an IT system which supports people and makes it easy. And I'm sure the same thing applies in Ontario. There was a lot of debate about whether we should take our very expensive and very elaborate general NHS IT system and modify it to meet this rather specific psychotherapy need. That would have cost millions and millions, and probably wouldn't have worked very well. And I think we were wise to choose to end up having a more slimmed down, fairly bespoke system, which just was designed to meet the needs of supporting therapists and patients in this initiative, and then think about how you might join that up to other things later when it was useful. And I know you've been having similar debates in Ontario.
Yes, indeed we have. Thank you. So Danielle, I'm wondering if we want to open it up. So how do you want to work this, Danielle? Have you been curating the questions? Because I have not been paying attention to this.
There are lots of good questions, and I will just say to everyone on the line, please continue to send them, because if we're not able to get through all of them, we can either follow up with David after and compile some of these in a different way and send them out. But also, and MTS will talk about this in a couple of minutes, we do have two other webinars as part of this series. And so some of these are great topics for us to explore in those as well. So keep sending your questions, and if we don't get to them right away, we will get back to you. First question, just to start off, because there were several people who asked this, and it's just a point of clarification. Paul, both you and David both made reference to stepping up or stepped care, and a few people just asked if you could explain what that means.
Yes, so step care is a system where, I mean, conventional psychotherapy is sort of, once a week face-to-face sessions. And of course, there's a very extensive and very good evidence base for that. But there's also an evolving and now quite large evidence base that shows that certainly people with the more mild to moderate problems often benefit from interventions which involve less therapist time, and therefore we call them low intensity in terms of the therapist time, such as guided self-help or computerized CBT. And in a step care system, what you do is, in order to effectively treat a large number of people with a limited resource, is you offer people in the more mild to moderate symptom range, initially a low intensity intervention, unless they strongly prefer the high intensity one. And many people we find respond very well to that. But if they don't, the idea is you step them up to the next level in terms of therapist input, what we call high intensity therapy, which is a more conventional face-to-face sessions. And there are a number of randomized controlled trials that have tested this out. There's a very nice Swedish study which brought people in the more mild to moderate range into the low intensity interventions. And then after 4 or 5 sessions, either stepped them up if they hadn't responded substantially, or kept them going at the low intensity end. And they found that the step up really improved response rates, but the initial course of low intensity got more than half of all the people to recover.
Can you speak at all to patient orientation or education? So how was this work explained to patients, or how are they oriented to it?
Well, I mean, we know that one of the best predictors of outcome in psychotherapy is how credible your treatment seems to you when you start it. That and therapeutic alliance are two of the big predictors. And so it's really important, whichever type of therapy you're using within high intensity or low intensity, that you explain to patients very clearly what's going to happen in the therapy and why you think it's helpful, and elicit their views about it. And that's a part of the sort of socialization. And I should have mentioned that in the IAP system, we really put a strong emphasis on choice. So you're not sort of just channeled in one direction. We explain what the options are and give you a choice, because people, when they have a preference, tend to do better with the treatment that they choose.
And I should mention there are some questions in the chat about exploring patient preference or provider preference for adopting a measurement-based care. That is going to be a key aspect of our second in this webinar series. Getting at some of the barriers. So that is just a shameless plug for you to keep attending as we cover the material.
I was actually listening to a talk given in our national forum today of a sort of initiative where you as a therapist, you got feedback on how far off track your patient was compared to what you might expect for other patients with a similar profile. And this work has also been done in the US, and it's really quite interesting, because it does seem as though we can get people to a similar endpoint of therapy, but saving up to 25% of therapist time if we're giving feedback as we go along. So it does seem as though this regular outcome data gives therapists some valuable information which allows them to target things more precisely.
I will say that there's a theme running through the questions that I think I know the answer to based on your presentation, but maybe it bears repeating. But several people have noted some pushback from some of their clinicians about doing this you really want us to do this at every session. And a few people who've just asked, is that true? You really need to do it at every session, or is it possible to space them out more?
Yes, I mean, obviously that was a debate that we had, and lots of people raised the same thing. And the answer is yes, we do it every session, that seems to be the only way to ensure that you get outcome data on everyone. But of course, you know, people only will do that if you teach them how to use the measures so they're helpful to see every session. And that's what we do. And they really do guide therapy. It's not just the total score that you're looking at, it's the individual items that you are. So, for example, if you're treating PTSD, you might see a decline in the items to do with intrusive memories, but you'll also want to look at the questionnaire on the avoidance items. And have they also gone down? In which case, you know, that's good. What you've been doing seems to have taken the patient in the right direction. But alternatively, you might get a reduction in the intrusive memories, but the avoidance items have gone up. So whatever you've been doing in therapy has ended up with them doing some things which are really not helpful for processing the trauma, even though the intrusions seem to be going down. So you get that sort of fine-grained detail from the measures. And if you're giving them every session, you can really relate what you did in the last session also to what's happening with the patient, and it helps you to individualize the treatment more and refine it. So, you know, we find it's incredibly useful to give it every session. Of course, I think a lot of people who say, you know, do you really have to give it every session, are thinking that it's going to waste therapy time. And of course, if that's what it was doing, that would be terrible. You absolutely don't want to spend any therapy time at all giving the measure. So you shouldn't be having patients filling in these measures in a therapy session. They should be filling them in before the session one way or another, and it should automatically come up on your computer screen. So there's no real wasted therapy time. As you heard in my talk, the way we tend to do it now is actually patients get an SMS message on the morning of their appointment. And if they're on the bus on the way to the appointment or in the waiting room, they just click on the buttons which answer the questions, and then they automatically go into the IT system. So there isn't really a burden for therapists at all. It's really an advantage. You just get some extra information to make the very best use of your precious therapy time.
Go ahead, Danielle.
No, you go ahead.
So there's two questions that are kind of human resource related. One is, how did you manage the scale up of human resources to meet the population need? Because that's a daunting proposition, creating something from nothing. And was there conflict with the private versus public system? And the second human resources question, which I can remind you, is what if anything are you monitoring in terms of therapist workload, burnout? You know, how's that going? And are there any COVID-related issues with that?
Yes, so very good questions. So, I mean, the first thing to say is, you know, you can't create a large system like we have in England overnight. You know, the IOP program is now 12 years old, and its scale has just gradually increased each year. In fact, the government has committed to increasing it by another 60% in terms of size in the next 3 years. So it keeps on expanding, but there's a limit to how quickly you can expand. And the primary limit to how quickly you can expand is actually, you know, the number of people who want to join and become trained each year, and your capacity to train people and do that well, as well as the sort of investment in resources. So that's the first thing about scaling up. You can't do it overnight. It needs to take time. Can you just remind me of the other bits of the questions, Paul?
Yes. So so there was a private versus public. How did was there conflict as you were scaling up that you would poach from private or encroach upon private? I think are probably the questions.
No, we haven't really found that as a conflict in England. And I think, you know, the important thing to remember, and I know this is true in Ontario, is that the vast majority of people in the community with common mental health problems aren't getting any treatment. So it's not like there's a competition. There's vast undertreatment. And so if you can produce a state system that is starting to address that, it's not really taking anything away from the other systems.
So there's no shortage of work. There's no shortage of business.
There really is no shortage of work. I mean, we have this mantra where we talk about parity of esteem between physical and mental health. And what we mean by that is that if you have a mental health problem, you should have the same right to evidence-based treatment as if you have cancer. Well, we're absolutely nowhere near that at the moment, even with this big initiative. You know, before we started IAPT with our state provision and our private provision, 1 in 4 people were getting therapy for their common mental health problems. And 8 years into the program, we moved to 1 in 3. A big increase in numbers, but it's still a minority of people who are getting reasonable treatment. And I know that's true in Ontario as well.
Yeah, that's remarkable. Can you describe both the supervision and the monitoring of well-being and burnout amongst the therapists?
Yes, okay. So, I mean, treating people with mental health problems is a very stressful thing to do. And so it is really important that people get properly supervised in that work, and we and supported, and we certainly see regular supervision as a key to that. So everyone in an IAPT service should be getting at least an hour of personal supervision on a one-to-one basis each week, and they will often also get some group supervision. Part of the supervision is just, you know, looking at the data, planning what you're going to do with each of the patients going on forwards. But it also should be feeding into continual professional development as well. So we have the idea that each year people should get access to good professional development to refine the skills that they think are important as they reflect on their caseload. So those are 2 of the key things. In healthcare systems, obviously, you know, our main focus is on the well-being of our clients, but we can't really be successful in improving the well-being of our clients if we don't treat ourselves in a similar way and focus on the well-being of the workforce as well. And that's been something that we think is an issue in IAPT, as in many other mental health services. And so we emphasize the importance of IAPT services developing sort of co-produced well-being initiatives for the staff within the service. And I think it's fair to say that at the moment, services vary quite a lot in how good those well-being services are, and, you know, how rigorously the service pays attention to that. And so that's another thing that you have to monitor, I think, closely. But thankfully, we do collect data on that as well and evolve it. COVID, of course, has been an enormous strain on the workforce. It is immensely difficult to keep a mental health service open when you have many staff who are going off ill because of COVID, and also staff are now finding themselves having to deliver treatment from their own home, which is not easy when schools are also closed at times and you've got young children around at home, and you don't necessarily have an ideal separate office to deliver the therapy from. These are all incredibly stressful situations. To be honest, I'm just flabbergasted at how the IAPT therapists have managed to keep up offering so many courses of treatment and getting such good outcomes in those circumstances. But I think many of them would say it is very stressful, and we're all looking forward to the vaccines and getting back to a more normal life. But those services that have managed it best are the ones that have felt that in these difficult circumstances, they have to pay more attention to staff well-being, even if the demands in the services seem particularly high. You can't skimp on that aspect of things. And so they are making sure that people still get their regular supervision and as often as before. But in addition, many of them are using Zoom and Teams and things like that to have something more like, you know, the conversation you have over the water cooler with your colleagues or a cup of coffee. So sort of separate times where people meet in groups regularly, which is a bit more social and really just supporting each other. And so we've ended up, you know, building that more into the system than you would in a normal clinic where, you know, face-to-face activities and going for lunch with people provides that function. You don't need to plan it in.
A couple of, oh, go ahead.
No, go ahead. I was trying to do your job, but like you go ahead.
We can alternate. A couple of questions about how is long-term recovery, or do you do long-term measurement on things like recovery and improvement? And how do you factor in reoccurrence into your recovery analysis?
Yes, so this is an incredibly good question. So, I mean, the reason why our government review body, NICE, recommends psychological therapies as first choice interventions in depression and anxiety is because they, in the randomized controlled trials at least, tend to have outcomes which are more sustained. So obviously medication, SSRIs and many other antidepressants can be really very valuable in the short term, but often people will want to discontinue them at some stage. And in many cases, there's a significant proportion of people who then relapse. But in many of the key trials of face-to-face psychological treatment versus medication, you find the relapse rate is not completely absent, but is significantly lower in those people who had the psychological treatment. And of course, that's because they have learnt skills in the therapy, which they can apply when things go wrong in their life in the future. So it can, to some extent, give them resilience against the sort of slings and arrows of outrageous fortune. But the research literature shows that that only happens if the therapy pays attention to relapse prevention during the initial course of therapy. So it only happens in those courses of CBT or interpersonal therapy or dynamic psychotherapy, where before you discharge people, you pay some attention to relapse prevention. And so because it's not absolutely guaranteed, it depends on getting these things right. It is actually quite important, I think, to monitor a longer term outcomes for therapies. Don't just assume that they're automatically there. And this is an area where I think the IAPS service hasn't got it fully right yet. What happened is that in the two big pilot projects that we did for IAPS at the start of the initiative, we did follow everyone up for 9 months after the end of treatment. And we found that the gains were very well maintained. So that encouraged everyone. But what we found is that the commissioners who fund services are not keen to pay for follow-up sessions after someone's finished treatment. And so the routine follow-up rates in IAPS services are much lower than we would like. But we're pretty unhappy about this. And so, because obviously, if you follow people up, you'll be able to learn a lot from the follow-up data about which of our interventions really are giving good, stable outcomes, which may be a bit more questionable about that. And also, you know, if you can spot the early signs of relapse and bring someone in for a few booster sessions, you're likely to avoid, you know, a full course of therapy. So what we're working on at the moment is phone apps, which will allow people, it gives them lots of self-help resources, so they're interested in using them. But it will also allow people to input their sort of outcome data once a month for a year after the end of treatment. As we bring them in, we hope we'll get much more consistent outcome data and learn a lot more about how to ensure that as many people as possible stay well. We've also brought in mindfulness-based cognitive therapy, which I think all of you in Toronto will know about, because one of the first trials that showed that mindfulness-based cognitive therapy reduces reoccurrence in recurrent depression was, of course, done in Toronto with Zindel Siegel. But of course, to know that that is really working, we also need the 1-year follow-up data. So this is something we're working on at the moment. It's a very good question.
So I think we have just an incredible amount of questions, really great engagement. When we started this, the idea was to ask the question, why measurement-based care in mental health and addictions? And I think the summary answer is that you simply can't achieve quality without it. And if you can't achieve quality, you cannot achieve the public mental health good that you intend to. And I'd say the roadmap that David Clark has developed is compelling, and it's imperative for us to follow it as closely as possible. And we're just so thankful, David, for your wisdom today, and also more thankful for your generosity in helping us along the way. Imtiaz, I'm going to hand it over to you to wrap things up, but thank you so much, David, for such an amazing presentation and question period.
Oh, it's been lovely to join you, and I look forward to seeing how you evolve your own practice in Ontario. It won't be a clone of what we do. I'm sure you'll do wonderful things building on the ideas you're developing.
Thanks, David and Paul. I want to thank you all for attending the first part of our webinar series on measurement-based care. Thanks for your advice for this, David. And what I would like to say is that I've learned a lot as well in the last hour with just listening to the conversations, reading some of the questions. I want to thank you, David, for your advice on measurement-based care. But I loved how you demonstrated how you can use measurement-based care to demonstrate improvement in value. You basically had emphasized how you can make it easy for us to collect and view data. I loved your comments about publishing outcomes early and being transparent. Really resonated with me. Using SMS and other digital technologies was very interesting. But we would love to hear from you. We will be sending out an evaluation survey. As we said, we will be doing a series of these, and we would love to hear how we can improve and what you would like to actually have addressed in the following sessions. We're looking to sending out as we said, Daniel has said this to you, the webinar, the recording of this webinar later on. But the next webinar series is being scheduled for March, where we will really focus on how measurement-based care is being implemented in clinical practices. And we would like to include actually some patients' perspective on measurement-based care. So look forward to that. More information on the sessions, registration, and so forth will be posted on the measurement-based care website at the center. So you look forward for those emails and to telling you more of these sessions coming out. And as I said, the recorded version of this webinar will be sent to all registrants who are scheduled for today, and we'll send that off later on. Daniel, I don't know if you have any final words.
No final words. So so we'll be in touch with more information, and just to thank you again to everyone for all of your great questions. They'll help us with shaping the future webinars as well. So thanks so much, everyone, and have a great evening.
Thank you. Bye now.